This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and I'm pleased tonight to have with us as a guest Dr. Heaton, who is a gynecologist and surgeon and obstetrician in Warner Robins, and has been here for a long time. Welcome, Dr. Heaton. Thank you for being here tonight. Now, tonight we're going to solicit some opinions that I think are often heard in doctors' lounges, but never make their way into the on the airwaves. Just about some ideas about how to make healthcare work a little more efficiently, and I think I don't think you're going to be shy tonight. At least I hope you will not be.
That's not my tendency.
That's right. That's what I've been given to understand. But maybe we could talk a little bit about how you came to be in this part of the world. You told me that you grew up in Savannah, Georgia. Is that right?
Yeah, I certainly did. I grew up in Savannah, Georgia. I went to Windsor Forest High School there. And then a local community college at that time has since become a university. I went to Armstrong State College.
Well, good. Now, so did you enjoy life in Savannah? Was that a pleasant,
a beautiful place.
A good time? And then you went to Armstrong State College there. Is that correct?
That's correct. It was community college at that time. Now it's, I think, South Atlantic University.
Yes. And you developed an interest in medicine there? Is that
no? That's you shouldn't get me sidetracked. That's too long a story.
Too long, but somehow
I had no intention of ever going to medical school.
No.
I was going to go into research.
Yes.
And I actually had people ask me, if I was applying to medical school. And I actually took the MedCats for a practice exam for the GRE.
Yes.
Actually helped me find what my deficiencies were, and I did better on the GRE than I did on that, but I did well on that.
Right.
And I just got curious if I could go somewhere, so I applied a few places.
Right, and I understand you were accepted by one of the, if I can say this, one of the best medical schools in the country, which was Vanderbilt. Is that right?
Vanderbilt, I think, I'm very proud to have come from there. I was very proud to be given the opportunity to go there. I do think it's fine.
And I think you won a scholarship there too, is that correct?
I was a Justin Potter Medical Scholar, a 4-year merit scholarship.
Wow, that's quite an honor. So kudos to you. Yeah. And you were telling me earlier that you wanted a more extravagant lifestyle than is normally findable by a medical student. Is that right?
I'm afraid I did step off the wheel there a little bit. Since I got to keep my merit scholarship regardless, I also got a military scholarship after the first year of living on beans and rice.
Yes.
And lived very well.
Yes.
On their stipend, with them paying for everything and the additional scholarship money.
Right. And then you were...
I took a cut and pay as a resident.
Oh, that's right. So it was you a step down. You had the merry life of a medical student, but... Then you went in the Army and you did your training there?
I did my training at Triple Army Medical Center, which I think was an outstanding training. We had 2 oncologists, 2 perinatologists, 2 infertility guys. It was a really good, I think, university level training program.
And that was in Hawaii, is that right?
Hawaii,
a beautiful hospital, and
up on the hill. We used to call it the Pink Palace.
Right. And so you had an enjoyable time there. You told me.
Well, I slept on a lot of nice beaches.
I bet that.
We used to be able to be worked 120 hours a week.
Yes. Well,
so it pretty much was sleeping on the beaches.
Well, both of us can condemn this present tendency towards 60-hour work weeks for our younger colleagues, but their students. But be that as it may. So you were there, and you then had an Army obligation. You were in the service altogether for how many years?
7 years.
7 years.
You had a 3-year obligation and a 4-year residency program.
Yes.
So I was in for 7 years.
And then you came to Warner Robins, did you? You think you said...
It was. I grew up in Savannah, Georgia, and I had in-laws in Savannah and parents in Jacksonville, and it just seemed like Middle Georgia just seemed like a good location.
And so you've been here for a number of years, and
since '89.
'89, I think you've
here in Warner Robins.
Here in Warner Robins, and you also practice some at the Houston County Medical Center. Is that correct?
I've been practicing there, doing surgery and obstetrics, a lot of obstetrics earlier in my career, but mostly at this point I'm a minimally invasive gynecologic surgeon. I specialize in pelvic pain disorders,
Yes.
avoiding incontinence disorders,
Yes.
and reconstructive surgery.
Yes, and so this may be a way to sort of get into some of your viewpoints, which I'm happy to have you here tonight to share about some of the inefficiencies in the American healthcare system in limiting office-based practice. I think the idea is that the billing system that exists causes certain practice patterns that might not be economically efficient.
Well, they absolutely do. I mean, they drive us to do things that are truly office-based procedures at the hospital at a tremendous increased cost, because hospitals are cost centers.
Yes.
They're very bureaucratic. They have tremendous monetary outlays they have to make due to all the government constraints upon them and all the things they've been ordered to do by the government but have not been funded.
Yes, so there's a lot of, I think we've had discussions on our show about that, about the unfunded mandates that are propagated on hospitals. And so there's coming from, and many of those mandates are very commendable, but they cause the hospital's cost to go up substantially. And so they often have substantial financial difficulties. And is it your thought that their fees are elevated because of that? I mean, they have these obligations to meet for mandates.
It's not just that their fees are elevated. It's that things are being forced to be done there that don't need to be done there because of the reimbursement system. They could stay at an doctor's office at a much cheaper cost.
Yes, yes.
Because we have a very inefficient system where the politicians promise but don't fund. Then the lobbyists pay the politicians. The politicians let the insurance lobbyists keep their premiums up. And the insurance companies won't let doctors do things in their offices and force things to go to the hospitals because they're unwilling to pay for the supplies at the doctor's office or to give them some small amount of money for saving them $7,000, $8,000.
So one of the things going on, I think we could get into the way that medicine in some way is controlled by the reimbursement system that exists. CPT codes, for instance, I mean, if there's a mechanism where the government, and actually Medicare, may say a certain procedure is going to be compensated for this particular amount of money, or some procedures are just non-compensated at all. And one of the things I think you're talking about is that if you do something in your office, the way that you're compensated by this code means that it's just not practical to do it, or it's difficult to do it.
Well, and the example I gave you earlier is I've done hysteroscopies and D&Cs, a procedure for evaluation of abnormal bleeding in women, especially as older women.
Yes.
In their perimenopausal and early menopausal years, in my office for over 20 years.
Yes.
I really see it as an office procedure.
Yes.
Easily done with a paracervical block.
Yes.
Safe. I've never had a significant complication in 20 years of doing them.
Yes.
In the last 10 years, I've saved the system, I've calculated over $4 million just with that one procedure in my office.
Yes.
What did I get for the $4 million? Zero.
You got nothing.
I got nothing. Matter of fact, I got even worse. I lost money because I amortized my own equipment, I used my own personnel,
Yes.
and I used my own supplies, which I didn't get paid for. But I did save my time, because if I took the same procedure to the hospital, it would have cost me an hour of my time. In my office, it takes 15 minutes of my time.
So in some ways, I mean, this is the kind of debate that maybe
But
the
why
public would be
don't
interested
I get
in.
a reward for saving $8,000 that the hospital gets?
Well, it's a complicated story, isn't it, about the way that money influences the decisions and how the system works. And I think as the American healthcare system undergoes substantial reform, a lot of these questions, I think, are going to be more before the public. So the hospitals, I mean, maybe they would argue their procedure is safer in that environment. Do you have a thought about that? I mean, would it be safer to do it in the hospital? Any evidence about that?
Well, I think the answer is 20 years and no significant complications.
Yes.
I mean, where's the safety issue?
So you think that what you'd like is more of a public debate about why things
are public debate,
and you don't think that's going on right now?
I absolutely don't. I don't think we've ever heard anything but the people with a one-payer notion saying that the free market has failed. Well, we haven't had a free market in medicine forever, and we don't need to have a completely free market capitalism, tooth and nail, is not for medicine, but we need a controlled free market where the people at the bottom that can't take care of themselves are protected. But if you don't have people have to pay part of it and be at risk, they won't choose to try to find lesser cost. I am the lowest cost provider of hysteroscopy in Middle Georgia. But I don't get patients for that. If we had any kind of free market, I would be sought out because I'm saving over $8,000 per procedure.
Yes, so it's a complicated story, isn't it, about services that are rendered and what is the appropriate cost. And I think it's fair, I mean, it's a fair statement to say that the patient consumer is pretty much that they just don't enter into these kind of discussions. So maybe they don't have enough information to do that.
Well, and they've been cut out of the discussion.
Yes.
Because, you know, their insurance is largely bought by their employer. The insurer makes their decisions of which physician they can see. And if they're out of network, they literally can't afford to come see you.
Well, why don't you explain what out of network is? I mean, maybe some people don't know what that is.
If I take an insurance contract, which is actually an indentured servitude contract, because there is no contracting, they tell me what they're going to do. Contract between two individuals normally is negotiated. Insurance companies don't negotiate with physicians. They give us this thing and they say, you sign it or you can't see our patients. That's their notion of a contract.
Yes. And so do you think, so I mean in this debate, I think one of the things that there's a lot of conversation about the role of insurance companies in the whole healthcare delivery system. And I would say it's fair to say that they've been demonized.
Please don't get me started on this one.
Well, all right. I hope you. Well, you know, as long as you don't get us in trouble with the federal communications people.
I won't be.
It'll be. I think it will be okay. But there's been a lot of criticism directed at insurance companies. So one of the things that happens, I guess we could both of us say, is the insurance companies, and besides their number one, I think they're profit-making organizations.
Absolutely.
And do you think that's influencing the American healthcare system, their profit motive?
Absolutely. I mean, I don't blame the insurance companies. They are not really the culprit. The federal government is.
Yes.
Because the federal government tried to use them to, quote, manage healthcare, which is ludicrous. Because when you let private, not-for-profit health insurance companies become for-profit to, quote, manage healthcare, their whole structure changed. They became fiduciarily responsible to their stockholders. That's their responsibility.
Yes.
They're not responsible to keep down the cost of medicine. They have no reason to. They make their money from the money they hold. They want the highest premium dollar that they can hold that they think the market will bear. That is their fiduciary responsibility to their stockholders.
Now, there used to be, I think some of the insurance companies were a nonprofit. Is that correct? I'm not an expert on this.
Many were.
And now that's pretty substantially changed.
Pretty much gone.
Are there any, do you know of any? Is Kaiser a nonprofit? You know about?
Yeah, I really don't know.
Blue Cross Blue Shield, I believe, changed.
They were a nonprofit and they are for profit.
Yes, and so there might be some kind of conflict in the role they have as purveyors of health insurance.
There's an absolute conflict, and they're still protected by antitrust law.
Yes, now
they are excluded from antitrust.
Now, neither of us are lawyers. I don't think you're a lawyer, but I know I'm not. But do you have any thoughts about how they got this exemption?
Well, I think the exemptions made sense in a status where you have not-for-profits because it allowed them to share actuarial data, and therefore decrease the overall cost by sharing data.
Yes.
But when you let for-profits share data, then they can collude against the patients and try to not pay for their services. They can collude against the providers and not pay them appropriately for their services to try to keep the money for their stockholders, which is their fiduciary responsibility. Their responsibility is to make the company profitable for the stockholders. That's their own responsibility. And
so well, I mean, you could say, I mean, there are profit motives that physicians have. I mean, is there a conflict there? I mean, do we have to depend on the honor of physicians not to let that occur? Do you think insurance companies?
I never would depend on the honor of individuals completely when money's involved in anything. That's why I'm not in favor of a truly capitalistic system.
Yes.
I'm in favor of a a managed capitalistic system that protects the people at the bottom end that can't protect themselves.
Now, let's talk about that. I mean, one of the things about healthcare is it's extremely expensive, and it's so expensive that one could imagine a situation where I think most Americans would say there's got to be a way this poor child can get care. And the government has a Medicaid system in place, and that many times will take care of that. But there's a class of people that doesn't cover. Can I throw you a softball and you want to talk about that?
There absolutely is a class that it doesn't cover, and I think there is a place for charitable organizations to step up, and I think that the government in the last situation needs to be the insurer of last choice to take
Yes.
care of the people that can't take care of themselves. I have no problem with that.
Yes.
There has to be some net between which we can't let people fall,
Right,
so they're
right,
just
right.
ignored.
Well, isn't that we have that now, though, do we not? So if you're
We have a
in,
net that's incorporating, pulling people into it that don't need to be in the net.
but I mean, I think anybody that's really sick could go to any emergency room, and there's sort of a mandate.
There's
that
an absolute mandate, a $50,000 fine if you don't go see them, if you're responsible to go see that
So
patient.
they're going to get emergency care.
They're going to get taken care of.
But there's a substantial shortfall, and it may be people that just, for whatever reason, they have enough money, they are not Medicaid eligible, and yet they don't have enough money to pay for health insurance. So that's a very substantial number of people, and I think one of the ideas is getting this class of people some kind of protection with a new system. Do you have any thoughts?
Part of my thoughts is part of the reason it costs too much for them to be insured is the for-profit insurance companies are deliberately excluding them by managing what things they offer to drive their policy amount up that they can charge, because they're deliberately excluding people that are poor, because if you look at that group of people, more of them have health issues. That's why a lot of them are poor, because they can't work on a regular basis.
Yes.
So if they're able to exclude those people, they're able to ensure year-to-year profitability. So insurance companies have no reason to try to get their premium level down to the point where these people can afford it. So there has to be some sort of system that drops the cost of care. And the best way to do that, as much as people don't like the thought of it, is the individual has to have some responsibility for their health care
Now, this
costs.
let me ask you the same question that was asked in the presidential debates. I think we had President Obama and John McCain were sitting there, and the question was asked, is health care a right or is it a responsibility? And which is it?
You know, that's a difficult question, because I'm never going to watch somebody suffer and not try to help. So I make it a right by my actions, but it truly is their responsibility.
So actually, neither of them answered it correctly, and I'll give you an A+ on your answer. The correct answer is it's both. So it's both a right and a responsibility, and parsing that out is a very complicated kind of thing. And certainly, I think the politicians, it's in their best interest to make it a right, and I think it's morally, I agree with that. But the responsibility seems to not be so talked about much.
And without putting the responsibility back into it, we can't afford it.
Yes. Well, so let's discuss what kind of responsibilities that the American citizen has to reduce health care costs. I mean, what do you think they need to do? They need to know something about what each procedure costs? I mean, do they have to be informed? Do they have to do what the doctor tells them?
It's absolutely hard to inform people well enough about a lot of things, as you well know. I mean, a lot of the things we do are so technically complicated. To give true informed consent to people really is difficult to do.
You know, I think you said something profound here. There is a limit. I mean, sometimes the situation is so complicated, the patient just needs to depend on the doctor's, have confidence in the doctor to at least spell the issues out for them. What about the ombudsman, if I could say that correctly, a person that's sort of a patient advocate? People suggest doing that, and it's advertised. If you talk to our nurses, they'll tell you what to do. If you're confused, do you have any thoughts about that? Getting opinions from
Opinions are only as good as the people you get them from is the problem.
Yes.
I think a lot of those things are more generated for the benefit of hospitals and trying to bring patients to their hospital, and maybe aren't as good as they could be medically as information. So, I'd have to take that on a case-by-case basis.
Yes.
If I think it was done correctly,
Right.
then I think having somebody is an outside third party
Right.
helping to be a free agent that really is trying to give you correct direction, if they're well educated enough and understand the system well enough, might be a good idea.
Now, one of the things about the patient responsibility issue, what sort of responsibilities a person that one can just go through a list to take medicine? What happens if a person abuses drugs? What happens if a person smokes? What happens if a person drinks, eats too much? I mean, all these responsibilities the person has. There's no real penalty as far as a financial penalty.
Well, I actually see no problems with people that have the income with rating them on their insurance based on that.
Yes.
The problem is you can't rate people at the bottom. At the bottom, you just have to have a heart.
Yes. And I think that's a physician responsibility to be able to render care. And traditionally, that's what happened. I mean, am I correct on that?
Well, we did a lot more of that in my younger years. I got referrals from churches and was told that people were indigent and they needed help. And I did surgeries that were not, life-saving and necessary, but they were to reduce human suffering and make them have a better quality of life. And I did them for absolutely nothing.
So maybe one of the things that happens, I mean, I'll just make this general comment. I think traditionally, the older days, most physicians would have patients that were indigent, or they would be rendering a substantial amount of charity care.
We did, and now we can't afford to.
Well, I think the system has changed, and I think that's regrettable that particular card in the deck has been removed, and there are a lot of reasons for that. But it's a substantial problem. I think the sort of the humanism has been diminished, and things are more on a cash basis. I mean, the system just makes that happen.
Well, I don't think that a lot of the physicians, at least from my age group, wanted it to change. These things are all imposed on us by the federal government's rules changes and insurance rules changes, and it's all come as things that we're just told this is the way it is.
Now, some of the things, I mean, what I'm extracting from our conversation is you're a physician, you're hard at work, you've been working here a long time, and these rules and regulations are just being propagated without any input. I mean, pretty much, you have no say-so in what rule comes down the line.
We used to have about that much paper and a chart for somebody that was in the hospital for a day or two for surgery. Now we have about that much.
Yes.
How much of that do you read, Dr. Robinson?
Well, that's a good question.
How much of that do you
well,
think
I'll have
is
to say a
useful
lot
at all?
of no. I think it's fair to say that if one does an operation, I mean, at least the amount of signatures necessary to sign, or there's a substantial amount of paperwork that floods the system.
You think we're doing any better job?
Because
of it?
I don't think because of that. But one of the things that goes on is that I guess what the government is attempting to do is to centralize a lot of the healthcare vagaries that were formerly sort of left out, and depending on, I guess, the goodwill of the physicians and just their commitment to quality care. And now this is being regulated substantially.
And that's part of the problem too, because they see medicine as something that you can make a flow chart with.
Yes.
And it's not. I'll give you a good example of what's wrong with the cost of medicine in this country right now. I saw a patient that was young and then so relatively low risk for some types of things that came in with right lower quadrant pain, severe. So the first things you'd think about is possible appendicitis, or an ovarian problem, since I only see women. And I examined the patient. Her abdominal exam was very unimpressive. If this woman had gone to an ER, she'd have got a full CT scan, all sorts of lab work, minimum bill $3,000.
Yes.
I evaluated her, no lab,
right.
assessed that it was probably myofascial pain, did a trigger point injection in her rectus muscle, all her pain went away, and I saved the system $3,000.
Yes.
What did I get for it?
Well, I mean, so with that, I think you're onto something a little bit about.
You can't be a flow sheet as a physician. You need to be a diagnostician, and that's not a flow sheet. It's a multi-channel thing where you're looking at something, you've seen things before, and they narrow down and you see what the truth is. You don't have to, if you take a good history and do a good physical, order 1,000 labs and 1,000 x-rays.
Right.
But if you don't, and you're wrong, you're going to get sued.
So one of the things going on is, and you sort of mentioned, what is the physician's, I guess one could say, benefit that comes to the physician for diminishing healthcare costs.
There's no benefit.
Well, and contrary-wise, there's a substantial risk because of malpractice issues.
Absolutely.
So if you're in that environment and that's what happens, the laws that regulate malpractice it punish physicians extraordinarily if there's some kind of test that's not there. So in general, one of the things, and this is often stated about the American healthcare system, the malpractice laws are driving the cost up because physicians tend to just be protective, protecting.
Order every test
and they order lots of tests that are extremely expensive.
And that was the second example I was going to give you.
Yes. And then one of the things, just to keep talking about this, it's very complicated, and I think on our show we'll have other discussions about this, about what it is that causes healthcare decisions to be made. And there are lots of factors out there.
Liability is
one of them is the malpractice issues. Another one that you've sort of spoken a little bit about are compensation arrangements that are often put in force by the government and by insurance companies. So these CPT codes say what can be paid for. So the example you gave is the insurance companies are discouraging care in a physician's office, and they're making, and the way that's being controlled is by the compensation arrangements. So what the public needs to finally understand is, what are the reasons for these decisions? What is the reason, and is it based on sound medical judgments? Is this evidence-based medicine that's influencing what occurs here? And some of the things we're going to talk about on our show is the paucity of evidence-based medicine that underlies the whole structure. So really good papers out there that might make a comment about just the kind of patient you saw. There are not too many of them. Where people, and one of the reasons for that is the outcome analysis in medical papers rarely makes any mention of cost. It's rare that anything in an outcome analysis about what happened to a particular disease process, that cost is mentioned. So, I think one of the things you'd mentioned earlier is you've written a number of papers here, and kudos to you for doing that. Mm-hmm. That might be an interesting one to pursue. Just thinking about how the cost that could be saved and bringing that to the public's attention.
Oh yeah, absolutely. I'm a big crusader for minimally invasive GYN surgery for women because it allows them to return to work frequently as little as a week after a laparoscopic hysterectomy, as opposed to 6 weeks when they have an open hysterectomy. And yet most hysterectomies in this country are still done open.
And so that's one of the things that actually needs to be thought about. And I'll say one thing is the information that makes its way into the medical community. I mean, we need to really focus, I think, substantially on some of these issues.
And they're not even looking at the whole cost, because the people that don't like the thought of minimally invasive surgery talk about a slight increase of equipment cost and anesthesia time. The trade-off is these people can leave the hospital as little as 8 hours after the surgery. Yes. And return to work in as little as a week.
Yes.
So they're not out of work for 6 weeks. They're out being productive.
Yes.
They're out, taking care of their families. They're not out of the economy, not generating product wherever they work. So when you just look at just the cost at the hospital, it's not the whole picture. The whole picture is, what do you save the whole economy?
Yes.
And nobody's looking at that when they say minimally invasive surgery is more expensive. In all, it's not. It saves money. It saves the employer money. The employer ought to be interested in it, but the insurance companies aren't, because they're experienced with laparoscopic gallbladders. They don't want minimally invasive surgery to be more prevalent, because what happened is they had a lot more gallbladders taken out once it became easy and painless to do it.
Well, Dr. Heaton, you know what? I think we could continue a long time. Maybe there's a place for your hat in the political ring, I'll say that.
I don't think so.
I think the audience tonight has heard some of the type of discussions that go on in physician lounges around the country. But thank you so much for coming, and thank you for your opinions and illumination. Thank you.
Thank you, sir, for having me.
Yes, sir. Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.